Welcome, everyone. Good evening, and thank you for joining us today. I'd like to start with a question for all of you, so you can reflect on this quickly. How many patients were sitting in your waiting room today with untreated sleep apnea? These are the patients who are probably telling you they grind their teeth, they wake up tired, morning headaches, and the underlying cause often goes undiagnosed. The reality, which you all know, is that dentists are in the best positions in healthcare to identify patients with risk for obstructive sleep apnea. And the challenge isn't seeing the signs, it's knowing and having options for what to do next. And that's why we are here today. My name is Harika Gudanti, and I'm the Chief Growth Officer at Sliiip. I'll clarify the spelling. It's spelled Sliiip, but pronounced sleep. So throughout this conversation, you might get confused between our brand name and the word Sleep. We pronounce it the same way. It's just that it's spelled with three I's. We are a virtual sleep medicine practice dedicated to helping providers like you test and treat sleep disorders through a very easy and fast process. We reduce the time for testing and treatment from months to weeks, and we're licensed in all 50 states. And today we're honored to be here. We have a wonderful speaker, Dr. Audrey Wells, who's also the Chief Medical Officer at Sliiip. I will switch the slides here so you can see a little bit more on her profile. She's a board certified sleep medicine physician, board certified obesity medicine physician, board certified in pediatrics as well, and a very strong advocate of menopause care. So with that, I'd like to welcome Dr. Audrey Wells and open the floor to you, Dr. Wells.
Thank you so much, Harika. I am going to share my screen. I have some slides to review tonight, and I want to say thanks to everybody for showing up and getting this learning as you're looking for new ways to assess patients and their risk for sleep apnea. So we're going to talk about how a savvy dentist finds it. Now, this is a picture I like to start out with. It is a sign near my home in St. Paul, Minnesota. And we all know this poster child of obstructive sleep apnea. It's the middle-aged man with a thick neck and snoring. And truly, sleep apnea screening and testing and even treatment has been built around this phenotype. And we're very happy to help all the Tonys of the world. But the landscape is changed and continues to change. So as we know more, we can do better. And it's time to widen our screening criteria. So I'm going to give you tonight 4 additional lenses with which to screen for sleep apnea. And as Harika mentioned, you as dentists are uniquely positioned to look for these profiles. You see the patient often, you look at their airway while they're lying down, you have the ability to connect their dental health with their systemic health, and you offer a non-PAP therapy to someone who might be avoiding a sleep evaluation because they think CPAP is the only option. So I'm going to base this talk around what contributes to obstructive sleep apnea risk. And I'll start with body fat. So it is true that the amount of body fat a person has and the distribution of that fat can increase risk for sleep apnea. And in fact, this is a feed-forward mechanism. So people with obesity have a higher risk of obstructive sleep apnea, and untreated obstructive sleep apnea will drive obesity and weight gain. And the reason is hungry and tired often run together. Sleep actually directly affects our metabolism, and this modulates our energy production and energy usage, such that if you aren't replenishing your energy through sleep, your brain and body will start to look for energy from food. So there's multiple metabolic drivers that are governed through hormones, and these hormones and processes are in a state of imbalance if someone isn't sleeping well. So sleep literally affects your body's energy management. And the unique thing about obesity as a risk factor or a driver for OSA is that it's modifiable. And so for the first patient profile I'll discuss today, just keep that in mind. Obesity is a modifiable risk factor. But untreated sleep apnea will actually sabotage efforts to lose weight. And it also makes it harder to maintain that weight loss. So, even in this modern time, when we have highly effective treatments for obesity, failing to address that feed forward mechanism of correcting the sleep apnea will reduce weight loss success and increase the likelihood that the patient will regain the weight that they worked so hard to lose. So at this time, tirzepatide or Zepbound is the medication approved for treating obesity and sleep apnea. So you can sort of shrink that obesity to OSA driver. But again, if a person has coexisting sleep apnea in addition to obesity, failing to address the sleep apnea will make weight loss harder and make weight loss less permanent. So it makes sense to treat both conditions at the same time. And you're going to see people in your office who are taking weight loss medication. It is more and more common. And now oral medications are starting to come out. And so patients who have both obesity and obstructive sleep apnea will wonder, what are the chances that weight loss will cure my sleep apnea? Well, it's not 100%. And people who have had bariatric surgery made this mistake over and over. So now that we know better, we're going to do better. We know that 20 to 25% of people who are diagnosed with sleep apnea have a body mass index in the normal range. So losing weight and getting down to a normal BMI doesn't always mean that sleep apnea goes away. In fact, there's about a 50-50 chance that weight loss done right, meaning you are sleeping, eating, and moving in the common sense way that makes sense for weight loss and weight maintenance, about 50-50 chance that weight loss done right will put your sleep apnea into remission. But there's a higher chance that sleep apnea severity will improve with weight loss. And what that does is it opens up choices. And that's important when you're talking about looking at oral appliance therapy as an alternative to PAP. When you're considering upper airway surgery, oral appliance therapy looks very attractive because it's non-invasive, and patients are much more amenable to opening up their choices as they're seeing success. So recognize that patients who have lost weight actually need to be re-evaluated for obstructive sleep apnea, and treating that residual sleep apnea that persists despite the weight loss can help make that weight loss permanent. Okay, so those are very important concepts for people who are choosing medical intervention for weight loss. And the truth is, sleep is a pillar of health. So you cannot skip sleep. You cannot eat crap. You cannot stay still and expect to be effective and permanent with your weight loss. And in fact, the goal is to live in a healthy body, not just a smaller body. And I will call upon our dental colleagues to reinforce this. So look for people who are modifying their biggest risk factor for sleep apnea with weight loss. Weight loss may lead to remission, but not necessarily a cure. So people still need to be supported, and they may be open to and a good candidate for a new treatment option like oral appliance therapy. And this gives you a chance to bust the myth that there's a one-to-one correlation with obesity and sleep apnea. So that's profile number one. Let's take a look at the second. The number two contributor to obstructive sleep apnea risk is age, specifically midlife and beyond. Now, a lot of people think that sleeping poorly is just part of aging. And I'm here to tell you, nope. People want to age better now, and they can. And Generation X and the baby boomers, so this is kind of my generation and above, they're more aware, they're more interested than ever before in aging well. And this means preserving heart health, preserving brain health, and reducing pain and inflammation. So recognize that every person 50 and above in your office is showing you dental data that is functionally a window into their health. You know this already. And more specifically, you're looking at the status of their nighttime breathing. You already know periodontal disease is a marker of systemic risk and heart disease. And sleep apnea can also be viewed the same way because it also causes low-grade inflammation and damage to blood vessels over years. So you already tell your patients that gum disease is connected to the heart. Well, sleep apnea is no different. In people who have dry mouth, that may indicate persistent mouth breathing, especially at night, which further drives inflammation. People can show tooth loss and enamel wear and decay, all related to having 8 hours of untreated sleep apnea per 24-hour period. And you're also looking at anatomy, which contributes to a repeatedly blocked airway at night, or anatomy that suggests bruxism and unconscious attempts to manage the tongue volume during sleep. And people aren't necessarily privy to this since, sleep is a state of unconsciousness, but they will tell you about the pain that they're experiencing, and you're in a position to address that directly. So, as we have increased attention on extending our health span as well as our lifespan, there's a big conversation going on about longevity and growing interest in prevention, in addition to health maintenance. One of the best things you can do to preserve heart, brain, and metabolic health as you age is to optimize your sleep health. Now, it's estimated that about 1 out of every 2 people, 65 years old plus, has some degree of sleep apnea. So it does make good sense to have the discussion about sleep apnea with your patients. Now, notice down at the bottom there, I've added medical conditions and substances, and this includes prescription drugs, especially opioids and sedatives, can include cannabis and alcohol. All of these are also more common with aging and compound risk. So if your patient is expressing frustration with aging or has an interest in aging well, you can highlight the impact that healthy sleep can provide. And truly, this changes the trajectory of their health so that they're not only living healthy, but literally improving the quality of their day-to-day life by improving their breathing at night. So profile number 2 are your patients who are in the second half of their lives. Now, I mentioned quality of life. I want to address the third most common contributor to obstructive sleep apnea risk, and this is related to the effect of sex and reproductive hormones. So I'm going to talk about a group that has historically been remarkably underserved, and that is perimenopausal women and postmenopausal women. Now, I started out my career in pediatrics, and one of the things that a lot of pediatricians will say is that kids are not small adults, which is true. Also, women are not just smaller men. And so their presentation, their risk factors, and even their test results can look much different than men. And recognize too that, like pediatrics, you have to have this element of time as you're looking at a woman's experience because she will go from puberty to having periods, oftentimes pregnancy, and then into perimenopause and menopause with a different hormonal milieu. And I like to think of this as kind of a symphony of different hormonal changes that affect a woman's sleep quality, her sleep quantity, and sleep timing. And as she ages and flirts with perimenopause and then moves into menopause, she will increasingly increase her risk for sleep disorders over time. So today I'm going to focus on the period from the late 30s to sort of the mid 50s when a woman is most likely to start encountering symptoms of perimenopause. So here on the slide, I have sort of a robust list of hormones that are related to sleep. And at the top, I've bolded the reproductive hormones estrogen and progesterone. So estrogen and progesterone are higher in premenopausal women, and knowing what these hormones do is important. So estrogen has a role in regulating body temperature, and estrogen also promotes sleep stability. Progesterone is a respiratory stimulant, so it protects breathing and promotes breathing. And progesterone increases the tone of the muscles around the soft tissue upper airway. So when estrogen and progesterone levels are high, they have a protective effect on sleep. This is a timeline showing age at the bottom and then different hormone levels on the left side here. And I want to draw your attention first to progesterone in this navy blue line. So in the premenopausal woman who is in her 30s, mid 30s or below, progesterone is high, but look at how it starts to fall even in the second half of the 30s. So this creates respiratory instability and usually some degree of airway collapse or flow limitation. And you can see that the progesterone tends to bottom out as a woman is turning 50 or thereabouts. Then look at estrogen in orange. So estrogen starts to fall a little bit in mid 30s, but really is on a downward trajectory in the 40s, such that by late 40s, the estrogen production is rather erratic. And this directly contributes to temperature fluctuations, also known as night sweats, during a woman's sleep, and it makes the sleeping experience terribly and frustratingly unreliable. Now, just for fun and to make sure everybody's awake, for all the women in this group, please go to the Q&A and let me know not only your experience as a woman, maybe a woman in midlife, but think about the women that you talk to and how they describe this frustrating experience as they are in their 40s and 50s. Their sleep tends to be effective. And the hormonal shifts finally settle down around early to mid 50s or so. Some of this is dependent on genetics, but in general, the age group that you want to look at is mid 30s to 50s as being at risk. So, women in this age group, they're commonly having this terrible sleep experience and they're fighting daytime tiredness as a result. And what gets labeled as menopause symptoms or even insomnia is actually undiagnosed obstructive sleep apnea. Because don't forget that progesterone is a respiratory stimulant and stabilizes the airway muscles. And then estrogen keeps you asleep and regulates your body temperature. So early untreated sleep disruption, if not recognized, actually sets the stage for chronic insomnia on top of obstructive sleep apnea. And that chronic insomnia can outlast the hormonal transition. And this is why so many women are asking, why am I so tired? Now, for me, I think this is a staggering statistic. I hope this blows your hair back. 90% of sleep apnea in women is undiagnosed. And I want to call your attention to the fact that women's sleep apnea symptoms are often different than that of men. So they're nonspecific, and I'll go over a little bit what those look like. I also want to highlight the idea that oftentimes women who go through a sleep test are diagnosed with quote unquote mild obstructive sleep apnea. And a lot of times this is related to having REM related sleep apnea, so breathing disorder that's isolated to REM sleep. But all the normal breathing that she does in non-REM sleep dilutes her AHI, or the apnea hypopnea index, and drives that AHI down into the mild range when in fact she has severe REM OSA. And that's associated with just as much cardiovascular disease. Another thing that can happen is that her own sleep interruptions with insomnia or a prolonged nighttime awakening makes the test less accurate. And so she may be characterized as having mild sleep apnea when her symptoms are anything but. And when you tell a woman that her sleep condition is mild, she is much less motivated to kind of pursue that as a treatment option. So I would like to reframe that and say something like clinically significant sleep apnea instead of mild, especially when you're trying to validate those symptoms. Now, finally, and I want everybody to understand, for those patients that you're seeing who have already had a sleep test and they tell you it's negative, recognize that the home sleep test and even an in-lab sleep study do have the potential for a false negative test. In fact, a home sleep test should actually be called inconclusive. And so, for someone who has persistent symptoms, retesting might be the way to go. And you can help us by screening for those symptoms. So, what does all this mean in terms of risk? Well, before menopause, in the premenopausal woman, those hormones, estrogen and progesterone, actually help keep the airway open and keep breathing and sleep stable, such that risk is low, maybe 1 in 5, maybe less. But after menopause, that protection fades and the airway becomes more collapsible, breathing becomes less stable, and sleep gets more fragmented. And that's why we see such a dramatic increase in sleep apnea in women who are going through menopause. It also means that in menopause, a woman's risk for sleep apnea is just as high as a man's risk, which is 1 in 3. So that's significant because I would imagine you have a lot of women in your waiting room. And she will not have the classic symptoms. She won't have the snoring and the gasping. She won't have the big neck and the big belly. She will tell you that she has insomnia, but a savvy dentist knows better. When you talk to women who have sleep related breathing disorders or perhaps another disorder, they don't describe sleepiness so much. What they will say is they have fatigue, and they will often say, I'm tired of being tired. And this is meaningful because when you apply a sleepiness scale like the Epworth Sleepiness Scale, they will score normal on such a test because it screens for sleepiness, not tired. Women in the perimenopause and menopause phase of their life are often frustrated with weight gain. And they have body fat distribution that's different than what they experienced earlier. They will put on more central fat, more visceral fat, even without changes in their diet or without changes in their physical activity. And even without major weight gain, risk for sleep apnea increases. Women also describe other nonspecific symptoms. They'll talk about headache, especially when waking up. Sometimes that's due to teeth clenching and grinding, which you will see in their mouth, of course. They describe mood changes, irritability, not having endurance for their day. They'll describe brain fog, problems with focusing. And again, they will tell you they have insomnia, not sleep apnea. And a lot of people buy into that stereotype. The reason they tell you they have insomnia is because that's how they are experiencing their sleep. So most often there's this middle of the night awakening that is prolonged. But what is waking them up in the first place? A savvy dentist knows that that could be a breathing event. That could be the sleep apnea that has yet to be diagnosed. Notice too, that graph that I showed you had hormones changing rapidly and erratically, especially estrogen. So in that perimenopause phase, one single sleep test may not capture the real picture. And so for this idea, I want to offer you my concept of the mammogram model in perimenopause, where sleep symptoms starting in the late 30s should be evaluated yearly or at least every other year through a woman's 50s to make sure sleep apnea is caught early and addressed appropriately. And there's precedence for this, okay? We have bone density scans. We do periodic lab work for cholesterol or blood glucose evaluation. We do mammograms, colonoscopies, and right in your office, those periodic dental cleanings and x-rays are another example of that health maintenance screening test that can impact your day-to-day life and the rest of your life. So you need a test to find out if sleep apnea is playing a role. And stopping at one test does a disservice to someone who is experiencing such drastic hormonal changes. All right, so we finished up the third most common sleep apnea contributor by taking a careful look at women in their late 30s and beyond. And I think it surprises people, dentists maybe, specialists, that perimenopause could be rearing its head in as early as the mid 30s. So really look at that as a new lens for assessing sleep apnea. And then down at the bottom there in the lower right-hand corner, I've added REM-related sleep apnea, which is again common in women and associated with just as much cardiovascular risk as if their entire sleep study showed the same AHI as just their REM. Okay? All right. So look for these women in your practice, validate their symptoms, open their eyes to the idea of better days and nights ahead. And this is a group who is especially amenable to oral appliance therapy as a solution because this group contains a lot of ideal candidates for this PAP alternative. I have my kids wondering what I am doing tonight. So they're going back downstairs. Okay. So finally, we're going to take a look at this middle row of sleep apnea contributors. So these things are right in your wheelhouse as you're having a front seat and a frequent opportunity to evaluate anatomy and airway and airway tissue collapsibility. So you're seeing the patient in your chair and lying down. So you have a front row seat to that. Let's talk about kids. So kids from 0 to 18 years old represent a group whose whole life can be impacted by fixing their sleep problem early on. And sleep apnea is common in this age group. Now, kids can be studied with home sleep testing, although in-lab polysomnogram is ideal, and historically that's been the gold standard. But the approach is worked out with the sleep medicine specialist who receives the referral. So that's a co-decision made with parents involved for sure. And if you look at the population of kids from age 0 to 18, there's sort of three subgroups that are defined in terms of sleep apnea risk. The first is infants, so neonatal up to early preschool age. This population is going to have non-tonsil related etiologies and probably markedly less likely to end up in a dental office because they don't have teeth. So I'm not going to spend time on them, but the next group is the preschool to school age group, maybe 2 to 12 years old. This group has high risk due to tonsillar hypertrophy, maybe enlarged adenoids as well. And if a sleep study shows significant sleep apnea, then they would have those removed. But there's a subset of this group that are candidates for palatal expansion, rapid palatal expansion as well, and even orthodontia because they have a small arch, they have a high arch, a small mandible, persistent mouth breathing. Sometimes you see the adenoid facies, the elongation of the face. And you'll see tooth decay in the primary teeth or early in the secondary teeth. So this is a group that needs a close look. And then finally, you have an older group of pediatric patients. This is the postpubertal, sometimes younger, whose weight or anatomy are going to impact the likelihood of sleep disordered breathing. In fact, a postpubertal teenager with sleep apnea symptoms can look a lot like an adult. And here, the anatomical risks are very similar and start to include TMD and bruxism. So these are search targets as you look at your patients. And finally, those children with non-typical development, they're at risk for sleep apnea because of differences in the neurorespiratory control of breathing. This includes low airway tone, and they may have anatomical features that affect their palate, their nose, their mandible. Here I'm talking about kids with Down syndrome, kids who have a lot of ADHD characteristics, maybe autism spectrum disorder and other syndromes. So they also need to have healthy sleep, not just to promote attention and memory, but also because sleep is related to emotional regulation, and they want to participate fully in all the academic and therapy pursuits that are meant to be beneficial to their potential and their experience. So the diagnosis of sleep apnea for kids is a little bit different, meaning that we lower the threshold for severity levels. And I make this point so that you can recognize to be more sensitive in your screening. So a normal AHI for a kid is going to be less than one airway event per hour of sleep. Some labs use 1.5. Mild is 1 to 5 range, moderate sleep apnea 5 to 10, and then severe sleep apnea in kids is 10 airway obstructions or more per hour of sleep. And the reason why is that the consequences of late diagnosis or missed diagnosis are more problematic because you're dealing with a growing brain and a growing body. So this can have long-lasting effects as their developmental windows are closing. And on that note, and as I come to the end of my slides here, I want to underscore the idea that sleep is literally for your brain and it's generated by your brain. And of course, your brain is your most important asset, and it's responsible for the way you think and how you feel and what you choose to do. So healthy sleep makes your brain new again. And this is a super busy slide. Feel free to screenshot it if you want. But the point here is that sleep apnea has an effect on every organ system and process in your body. It directly affects your heart. It affects your metabolism, your immune system, and your brain. So as you're talking to your patients about this, just like you're connecting gum disease with heart disease, anything you think about in terms of your physical body system can be made worse by untreated sleep apnea. It makes your body function as if it were older. And if you leave your sleep apnea untreated over time, of course, it will put you at risk for accumulating multiple medical problems. So we've reviewed 4 additional search targets for obstructive sleep apnea. And this is really to further make the typical stereotype, the no neck Tony, it's outdated. So when it comes to weight, 25% of people with sleep apnea do not have obesity. And about half of people with obesity who get to a normal weight will put their sleep apnea into remission. Age is the second biggest risk factor, and I mentioned that 1 in 2 adults age 65 or older will have some degree of sleep apnea, so it's worth screening. And people in their second half of life are more interested than ever in taking action to promote their health span and their longevity. Looking at women, 1 in 3 women who are perimenopausal, late perimenopausal, postmenopausal will have sleep apnea. And the perimenopausal phase specifically is an inflection point for that risk, which makes repeat testing entirely relevant. Remember that sleep apnea can be underestimated by home sleep tests in this group, and the frequency of false negative tests is not low. So repeat testing is very valid. And then finally, certain kids who come into your waiting room will have a need for sleep apnea testing. And for those kids, intervention can literally change the trajectory of their lives. Now, all of these groups have significant return on investment when sleep health is the goal, and dentists have the credibility and the opportunity to guide those patients to evaluation. Furthermore, dental interventions for sleep apnea are an important part of the sleep apnea treatment menu. And I consider myself and everyone at Sliiip.com to be an ally and a partner with dentists to promote sleep health. And we can say more about that soon. But as I close up here, I hope that this has generated some discussion. I hope that we can have some lively talk about who needs to be screened and a new approach to looking at your waiting room to figure out who needs to be tested. Harika, I'm going to move it over to you, and then I believe we have some time for Q&A.
Thank you,
I'm
Dr.
gonna
Wells. That was
switch
great.
my screen here. Can you see it?
Yes, I can see it.
And
Awesome.
then
Well, thank, yeah.
I'll jump in here as well and just Dr. Wells, appreciate your talk as well. I think just to hammer home the point, patients use different words to describe sleep issues. Like women use insomnia, fatigue, and not the usual prototypical loud snoring at all. No one wants to admit they snore. It's unladylike. And also I think part of the question you brought up about weight, people don't want to admit that that they may be overweight, and so they shy away from a diagnosis that seems to be frequently associated with weight issues. But like you mentioned as well earlier, the blame on the person here is actually unintended, because a lot of times the weight gain can be due to untreated sleep apnea. So to make sure that the weight loss is effective and long term and sustainable is to address the sleep issues. I think some people want to say, well, let me just lose the weight first, and then we'll deal with my sleep. And I think as the dental office, it's to circle back with these patients. Say, okay, let's give it a try. I'll see you back in 6 months for your next routine clinic cleaning, and check back in and see has your sleep issues improved? Because many of them, you'll be pleasantly surprised, don't have their sleep issues improved, and that's because likelihood is that their weight gain was due to sleep issues to begin with, rather than caused by, rather than the weight causing sleep issues. So something to consider. And I think even restless legs, patients who have restless legs and they may claim they only have restless legs, frequently get triggered by sleep apnea as well. So I think that comorbidity between sleep apnea and a lot of other sleep issues exist, and dental offices should be about widening that catchment rather than trying to narrow it to fat Tony, because fat Tony or no neck Tony is someone that, like it's a 5-year-old diagnosis. A 5-year-old can make that diagnosis. And we do have to do much better for our female patients, because I think part of our the reason for doing multiple nights of sleep testing, even though insurance only pays us for one night, is to ensure we reduce the event of false negatives. I mean, as a practice, we'd like to turn over our equipment a lot faster, and keeping this equipment out there longer than necessary actually costs us money, and we don't get paid as much, but it is the right thing to do clinically. So we reduce the false negatives that come about from that one night hit or miss. A lot of these online sleep test companies that are just selling sleep studies are doing their one night and giving their stamp of approval to patients, and people walk away thinking that, oh, I don't have it, when in actual fact they do it for one night, so there's a higher risk of false negatives. And then these sort of companies also rely on auto reads, AI-based reads. So it's never actually putting the clinical perspective to match the test results. And that's what we have to do as a medical practice, is see the patient, figure out what the clinical idea, whether this patient may have it, and then match it with the test results. Because if I look at the report, or if I look at the clinical note suggesting they may have it and the results look negative, then I'm going to look harder to find out why are these results negative and not matching. Again, allowing patients to actually get the right diagnosis rather than move on with their lives with a false negative and assuming everything's fine, and they go back to taking their melatonin or their ashwagandha and so on, or chamomile tea. And we're trying to avoid that. So, I think we're proud by the clinical work that we do on our end, the workflows that we have to reduce false negatives, because it's important for us to make sure we catch these patients, because it's hard for us as practitioners to go to sleep at night knowing that we've missed out a patient or diagnosis just because we were trying to be cheap and trying to get these tests done within one night and giving false reassurance to patients. So we welcome everyone to kind of look us up and see whether we would be a good fit for your practice. And Dr. Wells and I are here as great resource as well to each one of you, for as if you all are growing your practice and need some feedback and so on, happy to help, because we've been down this road. We understand how patients want to be treated. We do offer the ability for you not to only make the referral to us, but more importantly, you can actually have access to our schedule. So when you make the referral, and if you have Miss Smith in front of you before she's left your office, you can actually plug Miss Smith into our booking page so that she gets a confirmation of the appointment with us even before she's left your office. So this allows a lot closer integration between the dental office and the sleep medicine office, because what we find is the biggest drop off is once the patient walks out your door, you send us a referral, then here we are trying to play catch up and trying to connect with the patient, and it's harder to do that. So we have tried to avoid any sort of the usual pitfalls we find. We share all our clinical notes. We share updates as well. And then when the patient comes back to us for the return visit, we then discuss the test results. If the patient opts for the dental device, the office within 24 to 48 hours gets the full packet, the two clinical notes, the first visit, the follow-up visit, the test results, and the oral appliance prescription. Plus, we also schedule a 4-month follow-up visit automatically. So per the guidelines, we want to ensure that patients actually get the retest done, the efficacy testing done, so that we can confirm objectively that they are doing better. So thank you again, Dr. Wells, and I will shut up at this point.
You know,
No.
I just want to underscore the idea of timing here because when somebody is in a healthcare setting, they are in a teachable moment, and we can really take advantage of that momentum by getting them connected with a sleep evaluation, a comprehensive sleep evaluation, and quick test results, follow up. You know, that loop is something that we've worked very hard to tighten and be deliberate about. So really think that is part of delivering good sleep care is making it timely to enhance the idea that sleep is that important.
Mhm. Thank you. Exactly. And I think can you imagine as a dentist office, you have the liberty to screen as many patients as you want because a medical practice like ours is backing you up. So whether someone has comorbid insomnia or restless legs, it doesn't matter because we're going to help you take care of the patient in totality. So imagine a patient walks in to get their teeth cleaning done and then they walk out having their sleep issues addressed. I
Mhm.
think the dental office really needs to position themselves as airway centers, and we're more than happy to support them to do that because, if the patient has severe sleep apnea, you don't have to worry about that hot potato on your hands and having to get in touch with the primary care. We will manage it. We will set them up on CPAP. We will manage all of that, the compliance and share notes with the primary care. So we've got your back on that. And even though we're showing here the sleep image ring, we use various home sleep testing devices. The ENSO data, PPG is one of them as well. We also do the traditional type 3 devices, especially if a patient doesn't have a smartphone or is uncomfortable using their smartphone for testing and so on. So we do have different home sleep testing equipment depending on the patient need. And if they're really easy to get done, we send them out with the return label. And then it's a USPS return label to come back. So we send it out with a UPS, but USPS, so they just simply have to go down to their post box, raise the flag, and then dump in our test kit, hopefully gently, into the post box to get it back to us. So they don't have to travel to FedEx or UPS. So we try to make sure that the patient experience and journey is as smooth and seamless as possible. And once they've scanned the device back to us, that's when we'll schedule a follow-up visit. So that way the patients can be as quick as they need to be. We can see a patient the same week of the referral, get the test out to them within a couple of days, and then see them back within a week of that first visit. I've seen patients back in a week or less because they were like, I'm ready, just send it to me, Dr. Barr. And, I put the order in, the team contacts them, sends it out. They do the 2 nights of testing. They send it back to us. We also ensure that these patients, we are reviewing the data before we get the devices sent back to ensure that there's adequate data, because the last thing we want is a false negative, because then we have to explain to patients, oh, it's negative because 2 nights were done and you only had about 3 hours on this night and 2 hours on this night. So our team screens these results to make sure that we have adequate hours recorded. Otherwise, we prompt them to do a third night of testing. Because again, as a medical practice, we have to make sure we take this seriously. Because if we tell patients you don't have sleep apnea, we better be supporting that with our full clinical backing. And to do that, we need to ensure that the test results match the clinical acumen that we've developed when we saw the patient. So making a referral is easy, like the screen that we have over here. Once you recognize a patient, you go to our website, sliiip.com. You click on the referrals tab. It opens up a HIPAA compliant form. You'll put in the provider information, the patient information. There is a Dropbox feature if you have medical insurance card images, any demographic information. Even if a patient, and I want to be clear to everyone, even if a patient is midstream, what I mean by that is they've had a test result, they just can't get back in to see their regular provider. We are here to help. We don't necessarily want patients who are just completely naive to the journey. We're a medical practice. Even if they're on a CPAP or if they have a dental device and they got a test done recently, and we need to kind of see the patient to kind of get their new dental device approved, we can see them midstream. So the Dropbox feature on our referral document allows you to send us any sort of current documents that may be relevant to us. And then you hit submit. If you have the medical insurance information, that's what allow you to then book the appointment for the patient as well. So you can pencil them into our schedule. We will run their benefits, making sure that they are in network. We inform them if we're out of network beforehand. As a virtual practice, we cannot afford to screw this up. So because patients will switch off the phone and not answer our calls. Apparently they do that. And so we have to ensure that we verify their benefits, let them know that they're out of network in the event that they are. And then we also offer them a very competitive cash pay price because we want to ensure that we're able to care for most, if not all, your patients. We're not here to cherry pick your best insured patients. We're here to partner with you and make sure that we are able to handle all the patients that walk through your door. So our cash pay price is $150 for the initial consultation, $125 for all follow-up visits, and the home sleep test is priced at $250 for multiple nights of testing, return label included, along with interpretation by board-certified sleep physicians who actually do manual overreads and not just AI reads and rubber stamping the report. So we try to do a good job. We're not perfect. We may make mistakes. We will make mistakes. So feel free to connect with us. Info@Sliiip is our general inbox. But if there's anything else y'all need, just please reach out to us. We're here to help. We want to ensure that we can partner with each one of your practices and help grow the sleep dental field because I think, like we started off this conversation, we can't do this without our dental partners. We have to make sure patients have as many options as possible because we can't keep forcing round pegs into square hole and assuming that's good clinical care.